Hello and welcome to today's webinar from Healthcare for All Minnesota. My name is Dana Coulthard and I'll be hosting the webinar today. If we could go to the next slide, please. Today, we're very pleased to be hosting Senator John Marty, who will be presenting on the Minnesota Health Plan. It's time for universal health care. We will be having a Q&A following his presentation. Any questions you have, you can put in the Q&A box at the bottom of your screen. You can do that at any time during the presentation. And then at the end, we're going to have Ann Jones, who is our Vice Chair of Healthcare for All Minnesota, talk to us about a call to action and other references and the election of 2020. So, and then I'll be doing a wrap up at the end. If we can go to the next slide, please. So I'm going to do a quick introduction of Senator Marty, and then I'm going to be playing a video from the Minnesota Department of Health and Twin Cities Public Television that's going to be talking about the rising costs of healthcare in Minnesota. So Senator Marty will present right after that video. So Senator Marty is currently serving his 10th term in the Minnesota State Legislature. He's a graduate of St. Olaf. His legislative concerns are universal health care, economic justice, education, energy, environment, and ethics. He's on the Health and Human Service Finance and Policy Committee, ranking minority member, and the Energy and Utilities Finance and Policy and Finance. And he's the author of Healing Healthcare, The Case for a Common Sense Universal Health System, which describes the Minnesota Health Plan. All right, I am going to prepare this video to be shown. Just take me a minute. All right, I am going to have to go to this. All right.
In 1998, Minnesota spent $16 billion on healthcare, and family premiums for health insurance were about $5,000 per year. Nearly 20 years later, overall spending tripled, and families are now spending over $19,000 a year on premiums, and the state is spending over $50 billion. Take a look at this chart, because it illustrates the real pain of our current path. More and more of the dollars available in our state, and our personal budgets, are getting eaten up by healthcare, and it keeps growing faster than everything else, without regard for other prices, like housing and transportation. You personally may have felt this trend, like a rubber band that's getting harder to stretch. Maybe you feel it in your increasing deductibles or monthly premiums. It seems like your policy is covering less for the same price. Or maybe you feel it in the way added expenses are gobbling any raises or bonuses you might have landed in the past. And with all the dollars we're putting towards healthcare, everyone in our state still can't afford it. But it's not as if a lot of smart people haven't been trying to innovate. In the last 40 years, we've attempted all sorts of things. With managed care in the 80s and 90s, patients didn't like how their choices of which doctor to see and when was limited, and they pushed back. Health plan spending limits. They were pulled back because they didn't seem to constrain spending. Our first attempt at electronic medical records just didn't reduce costs as much as we'd hoped. Improved access to quality and cost information? It does not yet seem to drive substantive changes. Here are some of the factors we know can push us over the edge. Healthcare prices rise faster than our economy grows. New technologies in healthcare more often increase cost rather than save money. Administrative costs really add up. More of us, at all ages, develop chronic diseases. Many of us live in places that make it hard to be healthy. There are lots of mergers in the healthcare industry, meaning there's less competition to help reduce prices. And that's just some of them. There's no one factor that is causing healthcare spending to grow like this. Of course, we can't just let healthcare spending continue to grow. By 2027, we'd be looking at spending nearly $98 billion on healthcare in our state, with family premiums reaching $35,000 per family. We'll be spending $34 billion on hospitals, and spending on Medicare and Medicaid will be more than twice as high as it is now, $46 billion. Of course, we could all get together and try to get these costs under control now. With so many different things impacting spending, it won't be simple. For starters, we'll need to understand we need more than one solution because there isn't a silver bullet. Start investing in what keeps us healthy, including public health and social supports, not just what tries to fix us when we're broken. Make sure the changes we do make are backed up with good data about what actually reduced costs. Be serious about trying out new ideas, even if they create winners and losers. Most of us probably don't expect to be making twice as much money in 10 years as we are today. And if our incomes and state budgets can't keep up with growing healthcare costs, what are we going to be missing out on? How far can that rubber band stretch before it breaks?
Okay, I will just start. I believe I'm next on the agenda. So I want to bring up a PowerPoint, and I'm going to try and share the screen and hope it works. And okay, let me know if somebody's having trouble seeing it, but I hope that the PowerPoint begins now. I'm going to focus on some of the things about spending that the little video showed, but I also want to start by talking about where we're headed and the whole concept of healing healthcare. I start with the premise that our healthcare system is sick. People, you often hear them saying about how we're doing far better than other countries, and we do have some of the best doctors, nurses, etc., but we have a totally dysfunctional system for accessing the care. And I'll use one illustration. Alex Smith, the 26-year-old Richfield young man, not the only one, but one of many who has died from a lack of insulin in the richest country in the world. We have a system that kills people, and it's really unacceptable. Our healthcare system has been shown by COVID pandemic how sick it is. It was a crisis for many. Many of us had, okay, a good healthcare system, we felt, but for many others, it was failing to provide care, and it was driving many into bankruptcy or poverty. COVID didn't cause the problem, it simply made it worse, and it exposed the flaws of it. I'm going to talk about some of those flaws. First one, because of cost, people don't seek care when they need it. Co-pays, deductibles, lack of coverage, all those barriers are bad, and we know that. The trouble is, nobody's in charge of that, of fixing it and getting reasonable prices. So there are barriers that people can't face. There's no logical system. No one's in charge of planning. Nobody's coordinating services. I think we all recognize too many specialists, not enough general practitioners, nobody in charge of offering incentives to address the imbalance, too few doctors in rural communities. No one's addressing any of that. With a logical, organized healthcare system, we can make those services available on when and where they're needed, not based on when somebody's got a profit incentive to put something in place, but where there's a need. Pandemic exposed a lot of other problems as well. Profitability is driving our system, not public health. Hospitals and states are in what one governor called an eBay bidding war to get PPE, ventilators, and so on. One governor said, Montana, I think it was Montana's governor, Steve Bullock, said that they were outbid by the federal government. Arkansas was trying to purchase 500 ventilators when another state bid them, offering twice as much. Middlemen are making money off the system. When Keith Ellison and Governor Walz appropriately made price gouging an issue and made it a crime during the emergency, suppliers around the country continue to price gouge on a massive scale and legally. Pandemics exposed other flaws. The bureaucratic paperwork from insurance and billing is interfering with the time medical care providers should be providing care. And so during the pandemic, there have been efforts to only, I should say, not at least, to only temporarily reduce prior authorization and other paperwork. Prior authorization where a doctor has to get approval before doing certain treatments and so on. That is not only a cost factor, but that is reducing the quality of care because doctors have less time to treat the patients, more time to fill out paperwork. These flaws, I'd argue, can be fixed with a logical health system. That's not going to stop people from getting sick. It doesn't prevent something like COVID from happening, but it can coordinate providers and supplies and help people get the treatment they need efficiently and quickly. Here's where I want to start getting into the cost of things. That slide, the Department of Health video points out, I think they use the word 4 decades. It's actually been about 5 decades we've spent trying to fix healthcare to make it less expensive. And we failed. The slide presentation, the video is pretty clear on that. We try all these things. Well, that didn't work as good as we thought. Basically, didn't work at all. This, we tried that. Well, people weren't happy with that. Well, this approach. Tried one after another, and they haven't worked. We're now spending twice what virtually every other country, with maybe 10 or 12 exceptions, is spending on healthcare. Twice as much with worse outcomes. We are 4% and 5% of the world's population. We've had more than a fifth of the deaths from COVID. We're the most expensive and the least prepared in some ways. Not the least prepared, but the least prepared among developed nations. With the Minnesota Health Plan, which is a proposal I'm pitching and want to make a case for today, before we try to save money, let's not forget what the goal of our healthcare system is. Keep people healthy and get them care when they need them. You don't design a healthcare system to save money. You design a healthcare system to keep people healthy and get the care they need. Remember that goal. That's what we're trying to do. Keep people healthy and get them care when they need, period. Nothing else. It's not designed around somebody's bottom line, but designed to keep people healthy and get care when they need it. My argument is, we always like to say we want the best of everything. Well, why don't we try and create the best healthcare system in the world? Not, well, others might do better, but we're going to do pretty good. Let's try and create the best one in the world. And that's what we do if we're focusing on the goal of keeping people healthy and so on. I talked many times, many of you have heard this, that designing Minnesota Health Plan was meant to meet certain principles I think any good healthcare system would have. First one, cover everyone with no exceptions under Minnesota Health Plan. Well, I'll get into more details later. I'll just go through the principles quickly. Cover all medical needs, all medical needs. Your teeth are as important as your fingers and toes. Your mental health is as important as your physical health, etc. We want patients to choose their doctors and medical decisions to be made by patients and their doctors. A patient and doctor-driven system, not an insurance company or government or employer-driven system. We want to reduce costs not by denying care. We can do it by cutting administrative costs and by logical pricing. Want it to be affordable, all premiums based on income. We want to focus on preventive care to improve health. We want enough providers to avoid waiting lines. We want to maintain leadership in medical care research and technology. And here Minnesota really is, not just the US has been a leader in much of medical care research and technology, but Minnesota among the states has been one of the best. And yet we put so many barriers to that research. You come up with a new scheme for how you want to treat people, a new protocol that seems to work well. You can't just implement it and try it out. You have to get approval from each of the payers, all the insurance companies and employers and everybody else. And so we can't try things on a bigger scale when they seem to be working very well. And there are plenty of examples of that if you want to hear more later. We want to pay providers in a fair and timely manner. I think that's one of the problems we have now. It's not fair, it's inequitable. Some get paid way more than they need. Others can't keep their doors open. And we want a simple and understandable funding system. These principles are something I would argue any good healthcare system meets. I would argue our current system meets none of them. Cover a lot of people, cover a lot of things. Some decisions are made by patients and their providers, et cetera. But our Minnesota health plan would be designed to meet these principles and would be legally, by the law, would be bound to them. How does it work? Well, it covers everyone with no exceptions. You don't have to qualify. You don't have the right worry about insurance or any of those things. We'd have a maximum 2-page application form. You live here, you're covered. I say 2-page because I know you could fit it on 2 pages. I'm not sure why it wouldn't be only 1 page, but you live in Minnesota, you're covered. We'd be seeking a federal waiver to prevent other states from dumping patients here by charging those states for their patients. It doesn't affect the patients. We're going to care for them regardless. It affects the other states. You would be able to be covered if you live in Wisconsin but work in Minnesota because your employer is already paying into the system if so, and you'd be paying premiums based on incomes just like every Minnesotan would. And if you're a Minnesotan and you're out of state traveling, you get the same as you have now. You get coverage wherever you are. Minnesota health plan would pay medical bills everywhere just like your current plan would. People traveling from elsewhere in Minnesota would get care, but the Minnesota health plan would bill their insurance plans the same way they currently do. Hospitals and clinics currently do. So there wouldn't be any real change for people coming in. And when we say we'd be really reducing like hospitals, the way we're paying them, they wouldn't be billing Minnesotans, but for people from other states, yes, we would be billing them. Covers all medical needs. Well, that's something I've mentioned many times. It avoids the problems with long-term care insurance, which most of us don't have. And those that do, it doesn't work well. Some people have had a policy and then at the end of 15 years, when they're getting closer to the age when they need it, all of a sudden their premiums double or triple. Then they drop their coverage, they lose all the premiums they paid in the past. It doesn't do any good. The only coverage for long-term care that's income related is the housing portion of long-term care. Medical care and treatment would be fully covered for all people as it is under Medicaid and medical assistance, but board and housing costs, unless you would be Medicaid eligible, you would be paying for your own board and care costs. So if you went to a nice assisted living facility, you're going to be paying for that, but the medical treatment portion would be covered by the Minnesota health plan. You choose your doctors and hospitals and medical decisions made by you and your doctor. This is a real quality of care issue. Medical decisions made under prior authorization, which I mentioned earlier, which a lot of folks have been waiving temporarily under the COVID plan because it was interfering with the care that your medical providers could give. So, well, in this emergency, let's take it away. Well, it's also interfering with your care on an ongoing basis. Here's medical insurance company clerks are making medical decisions for you. They're not medical doctors. Maybe they're overseen by medical providers, but the medical doctors who are overseeing them aren't visiting you as a patient. They're just looking at some chart and some formula and saying, oh, you're seeing a patient for this. Well, you should try this first, or you should try that protocol instead. Ask doctors how much time and energy they spend trying to get prior authorization. Insurance companies should not be making treatment decisions, nor should employers or government. This is a true quality of care issue. I'd argue Minnesota health plan is patient-centered care. You're covered for all your needs. You choose the care you want. You're the one in charge. Affordable to all. Premiums based on income. Everyone's covered. Everyone pays. Nobody faces unaffordable costs. The Minnesota health plan legislation would have Minnesota employers would be paying a health tax to cover costs. They'd be freed from all the shopping around for and the paying for healthcare premiums they currently do. And so the employers would have a huge burden off their back. But they'd be paying one share, and premiums for individuals, unlike the premiums you currently pay, would be based on your income, based on your ability to pay. You got to think of when we're talking about the cost of the system, which is now well over $50 billion, as the 3-year-old slideshow film showed. More than half the system, though, is already covered by state and federal government. We'd be capturing that money, putting it all into paying for it. The other half would come from those income-based premiums. Even low-income people would be paying something. High-income people would pay more on that sliding scale. so nobody would face these copays and deductibles and out-of-pocket expenses. When they talk about when you shop for healthcare, what's the out-of-pocket maximum? You're not worried about that because you don't have them, period. Workers' comp premiums for businesses would drop sharply. Auto insurance premiums would drop sharply. If you have a back injury, you go see a doctor, you're not going to be filling out lots of forms in the doctor's office while you wait, assuring them that it was or was not caused at work or by an auto accident. And it avoids all the lawsuits and legal fights over who's responsible. Minnesota Health Plan would pay, so premiums for workers' comp and auto insurance would go down. Focus on prevention, public health. Everybody talks about the importance of this. Even there was a mention of this in the Department of Health slideshow, which is appropriate. It's no longer an afterthought here. Public health efforts would not be competing against education and transportation and the court system and the environment and everything else. Public health would be funded by the Minnesota Health Plan. And given the fact we're spending a fraction of a percent on public health, fraction of 1%, a small fraction, you know, maybe we might find that the health plan might find it appropriate to spend several times that much on prevention, public health, to address obesity and other public health problems. School nurses, every school should have a nurse. They wouldn't be competing against education funding. They'd be funded by the Minnesota Health Plan. And it would be, why do you want public health nurses in the schools? Well, that's where kids might well get their vaccinations. That's where they should get a lot of their care, because that's the place the kids are. You don't have to try and set up appointments from elsewhere. A lot of work can be done by a school nurse, public health nursing. Got to watch my time. I'm going to keep try and speed this up here a little bit. Ensure an adequate supply of providers to meet the needs and prevent long waiting lists. Yes, there is no typical connection between shortage of providers and universal healthcare system. People often point to Canada. Well, yes, there has been a problem there, but a lot of other countries with universal healthcare don't have waiting lists, and in our country, we do have waiting lists. Appropriate supply of medical providers. That matters. Currently, we've got, some people say, oh, rural hospitals are going to suffer if we have a universal healthcare system. No, they're suffering now. We're closing rural hospitals. We'll think of Fairmont, Minnesota, or Albert Lee, hugely downsized based on corporate business plans. In those cases, Mayo's business plan, not based on the need in the community, purely based on somebody's corporate business plan. We've got a huge shortage of providers in some areas. Some types of providers we have shortages of statewide. Nobody's in charge of that now, and our system would be required to help work with med schools and other medical training facilities, trying to make sure we have enough providers everywhere. We would pay hospitals and nursing homes to an annual budget. Like schools, we'd be paying providers fairly for the services they provide, like the rest of the economy. I may get into this later if we have time, but fee for service has been vilified in healthcare when the rest of the economy, virtually everything we have in our economy, 99% of the economy is paid for with either price for product or fee for service. You pay a fee or a price based on what you're buying. And instead of trying to come up with convoluted new incentive programs that are going to somehow do better, if you look at the incentive programs we've been trying, as the MDH film or video showed, we failed. They've been not successful. Minnesota Health Plan would address the flaws. The cost barriers to access care would eliminate. A logical system for planning and coordination. That doesn't mean there wouldn't have been a shortage of PPE. The whole nation was way behind on that. But we have no system in place for quickly ramping up supply chain. We have nobody thinking about that. Each hospital is responsible for stocking up on its own, and it's a bidding war then between them. We address all of that with a logical system. A system driven by public health, not profit, would end the bidding wars and price gouging. We'd be slashing bureaucratic paperwork, saving money and improving care. Okay, so it sounds like a great health plan. I hope you feel it is. Can we afford it? How can we afford to cover everyone? It might sound counterintuitive, but by fair pricing and eliminating bureaucracy, we do save money. Economic analysis around the world shows it's less expensive to cover everyone, medical needs for all people, through a logical single payer system. Most of you may know what single payer is. It's real briefly here. Doctors and hospitals are paid by one payer, not multiple ones. Right now we have insurance companies, government, businesses, and individuals. In other words, out of 5.5 million Minnesotans, there are probably about 5.6 million payers. I mean, probably the only way we can get universal health care in American politics is a single payer system. That's my premise. I can get to that later. Huge increase in taxes. A year or two ago, the Mercatus Center at George Mason University, which in the footnote says here is Koch brothers funded, they did an analysis, a thorough analysis, they said, of Bernie Sanders' Medicare for All. They claimed it cost $32 trillion more over the next 10 years. Wall Street Journal and virtually every publication, including a lot of Democratic-leaning institutions, said, see, look how expensive it is. I think you could argue it's about $2 trillion less. Some people said that you could get those same numbers out of the Mercatus Center study themselves. How you come up with that? Well, they're saying $32 trillion more is the cost the government's going to be paying under that. Government will pay $32 trillion more. But the other analysis, the $2 trillion less, might be maybe we're spending $34 trillion less in the private sector over those 10 years. Most analyses that are not Koch brothers funded have shown that Medicare for All should actually save money. We've been trying to get and still waiting for, and next year I hope we can fund a rigorous economic analysis comparing Minnesota Health Plan to our current system. This is a study I pulled this from my slide presentations a couple of years ago because it's dated now. You can see 2007, Minnesota Healthcare Access Commission. State of Colorado did the same as well. This is prior to the Affordable Care Act. Remember, Obama was elected 2008. Affordable Care Act was fought over in 2009 and passed in 2010. Colorado said, hey, we've got two big problems in the state. A lot of people are uninsured and healthcare spending is too high. Give us your best shot. 24 different groups, I believe it was, came in with proposals. The commission picked the best four they saw, and they hired the Lewin Group, which is a health consulting, health economics firm, to do an analysis of it. They took these four proposals and they wrote a 250-page report. I think you can still find it on the website. There's a little footnote here at the bottom showing it. But I took the numbers from that report, didn't doctor them up or anything. I just figured, let's figure out what this means. These summaries of the plans don't say much. The first three are various variations of things. I'd argue they're like the Affordable Care Act. We're going to do more of this. We're going to increase access to public programs and so on. But I took the Colorado, they said just under 800,000 uninsured. First plan cut that down almost in half. Second one cut it further. Third one cut it further. The fourth one, which if you read the notes at the bottom, it's a universal health care system with a patient choice of provider. It didn't take 6 digits. 0 people remain uninsured under that proposal. It's pretty good. That's their goal, one of their goals. The other goal was save money. Unfortunately, it cost $271 million more for this one plan. The next one, $600 million more. Next one, $1.3 billion. And the bottom one had the biggest number of all, $1.4 billion, but it's got a little minus sign in front of it. You can see there. In other words, it was less expensive. So what the Colorado plan, what did they decide? Well, only one of the plans they looked at covered everyone. Only one of them saved money. In other words, given their two goals of saving money and covering everyone, only one plan worked. But experts decided single payer isn't feasible. So instead of fighting for something that works, let's pick something that doesn't work and we'll fight for that instead. I know that's not really what they would have said about this. They would have said, well, single payer isn't feasible, so let's pick something that's feasible and fight for that instead. But it's the other plans didn't work and they're going to fight for them instead. Isn't that how we ended up with the Affordable Care Act? I would argue that Obama said it's not feasible, so we'll do something else. And well, is it going to cover everyone? No. Is it going to save money? No, but let's try it anyway. And I like this cartoon in the New Yorker several years ago, sort of makes you stop and think. Minnesota Health Plan is less expensive. How? I'd argue 2 ways: logical pricing and cutting bureaucracy. And I'm afraid I'm getting short on time, so I better wrap this up quickly. Minnesota Health Plan negotiates fair prices. Huge disparities under our preposterous current system. Knee replacement, This was done in about a 5-year-old study now. $3,400 at the cheapest hospital, $55,800 the most expensive. You do the math, that's 16-to-1 price disparity. 16 times as much at one place as another. The cheap one wasn't doing it at a bargain basement sale rate. It wasn't a loss leader to get people in the hospital. They don't do that. That's the cost they had to deliver the care. And they were making money charging it. The other hospital, top end, they were making lots of money charging it. Minnesota Health Plan would also eliminate insurance and billing bureaucracy. I like to use the analogy of what if we funded our schools like hospitals? We would have charge each student for time and resources. That takes teacher time and school administrator time. Calculate how much time and energy they spent on each student. There's huge variation. Special needs kids take a lot more. School insurance, because it's so expensive, you can have insurance plans for it. You know, employers would cover it for their employees if they want to attract their employees. That's the way we do it now. With healthcare, we do the same thing with insurance. Think of that billing and insurance bureaucracy, not just in the school's billing office and collections office that the teachers and all the school administrators have to feed stuff to. But then you'd have a Blue Plus for education. The health partners could have an education partners, Educa instead of Medica. Minnesota Care could have a MinLearn. Think of the bureaucracy of each of those insurance companies and all of the paperwork they're sending to the parents, and the parents sending to schools, and the schools sending to everyone else. Think of that. Will this improve education? Of course not. Shifts resources from teaching to billing. Students be forced to switch schools if they're out of network, don't have coverage. You don't get an education. Nobody's suggesting it. Nobody would want to do that. We would be proposing under our system to pay hospitals and institutions like nursing homes. We pay institutional care with an annual budget. You negotiate it based on what the needs are, and they don't have to spend all their time billing. As I mentioned, for people coming in from out of state and so on, they'd have a few cases where they'd be billing, but 90-some% of the care they're giving would be just based on their global budget. Would it save money? Of course, the health plan would not be saving money if you did it. If education would be, you'd have that huge billing and collection bureaucracy. So we want to get out of we want to fund healthcare more the way we fund education, where everybody's covered and you don't have to track every dollar going everywhere. We want to spend our money healing people, not billing people. Politics, real quickly. Aren't there many different ways to deliver universal healthcare? Not in the US. Why? Powerful interests manipulate the political system. The system with gaps is going to lead people falling through those cracks. I'm not going to go in more detail because I don't have time, but if you disagree, show me other proposals. Show me how they're going to get to universal health care. I've yet to see a single one that would work in our country, period. You look at the plans that all candidates for office offer. Oh, we're going to do this. We're going to cover more people. How many say we're going to cover everyone? Well, we're going to get there. When? How? They don't have a plan. Pandemic is changing the politics of universal health care, at least for the first month or so. Right after the pandemic started shutting down things, Republicans and Democrats who opposed Medicare for all, at least briefly, they favored Medicare for all, but just for this one illness. They wanted to have no copays, no deductibles. You can go to any provider. They're going to give care. You don't have to have insurance. We're going to cover you all. But that faded quickly. People in the public, however, are beginning to recognize what we've been saying. Everybody is at risk if we don't treat infectious diseases for everyone. And so we have to do that. We want to do that. Politics have changed. Maybe not all the elected officials, but the public is seeing change is more urgent. When I look at the candidates running for Senate in Minnesota, I see a sea change of how many are being supportive of universal health care. FAQs, I better check the time. I guess I got a few more minutes, I hope. Government health care. That's the first question you always get when you get this. When we introduced the bill several months after Trump was first elected, we weren't going to have a news conference, but I talked with the House author and we decided, well, maybe we should. We had so many authors. Let's at least talk it up. So we had a news conference and I predicted what the first question was going to be. Didn't the voters reject government health care and now you're proposing it? And I'd say, no, this isn't government health care. We don't want government employers or insurance companies interfering with health care. We want a patient and provider-based system. talk more about that if there are questions about it. Is fee for service the problem? Perhaps. When we pay the wrong amounts for the wrong things, yes. But as I mentioned earlier, our entire economy works by fee for service or price for product. Convoluted payment reforms have made the system more costly. HMOs, PPOs, IHPs, all of these new things, accountable care organizations, all of those systems, they've all got, what they're trying to do is say, we're going to find a better way to pay. Better way than salary, better way than fee for service. We're going to pay people on some system that's going to somehow provide these huge insurance providers or these hospital systems, Mayo or Allina. We just give them a lump sum per people. Somehow they're going to have the incentive to treat people more carefully, and they're going to save money. It hasn't worked. It's set up a huge new bureaucracy. I think some of you have seen the PNHP slides of showing how healthcare administrative expenses have gone through the roof, and how the number of doctors has stayed relatively flat compared to 30-fold increase in healthcare bureaucrats. What about loss of insurance industry jobs? It's a huge matter that we have a moral and economic obligation to address. Dislocated worker benefits and retraining. The Minnesota Health Plan provides funding for that. The National Medicare for All proposals provide funding for that as well. It's a moral obligation we have to do. It does change the economy. Not huge, not nearly the impact of the COVID crisis. COVID crisis threw huge chunks of the economy out of whack. There was one analysis of a single payer plan in Minnesota done by the Lewin Group. Again, the reason I mentioned the Lewin Group earlier, by the way, is they're owned by United Health Group. They are not biased in favor of single payer. It would put their employer out of business if we had a single payer system. But the Lewin Group did an economic analysis of single payer here, estimated roughly 40,000 workers could lose their jobs under this. That's a big issue, a huge issue. But to put it in perspective, in any given month, normally, not during COVID, but any given month, there are about 155,000 employees leave jobs in any given month. Some of them are because they're laid off, some of them because they're retiring, some of them because they're switching to new jobs. But total altogether, we have about 155,000 people leaving a job in any given month. In a good time, we might have 158,000 new jobs, people taking new jobs in that month. In a down time, might be 140,000 people and so on. But even so, the number of people in any 1 month is about 4 times the total number we'd have on a one-time basis we have to address. Again, it's a huge issue, but it's a manageable issue, and we do provide funding for it. What about a public option? You're going to hear this a lot from people. During the presidential debates, when there were 20 Democrats running, almost all of them had the word Medicare and for all in their platform somehow. Medicare for all who want it was a favorite to talk about a public option. It's better than the current system, but it doesn't change much. First of all, in Minnesota, those who buy individual policies through the exchange or whatever is about 3% of the public. Okay, so what about the other 90-some%? It's not going to change much. You'd still be paying premiums, co-pays, deductibles. They might be a little more affordable, at least initially, though if it's covering its way, the other plans are going to dump their sick customers into it. There are ways they can do that, and it's going to make it worse. So I don't think it changes much. I favor it. It's a small thing we should do now, but I don't want to spend years working on it. I want to move to universal healthcare system now. What about long waiting times? I mentioned this earlier. In Canada, they actually have a group that's fighting against waiting times because it has been a problem in Canada. They have an advocacy group fighting it. And they keep pointing out, it doesn't correlate to single payer. It doesn't correlate to universal health care. It correlates to not having enough providers. Minnesota Health Plan would be legally required to find sufficient providers to meet the needs. How you can help? Speak out. Elections matter. This is the time to talk. Thank you. And with that, I'll open up for questions and discussions and stop sharing.
Thank you, Senator Marty. We do have a number of questions that have come through. I guess I'll start with, could you talk about how the Minnesota Health Plan would work with Medicare for a Minnesota resident?
Sure. What Minnesota Health Plan would do for Medicare would, what we'd be asking, and again, the bill is written in such a way that if we can't get waivers for everything we want waivers for, the Health Plan Board is responsible for trying to work around it. But bottom line is we would be people, if you're covered by Medicare, you'll always have Medicare coverage if you move out of state, so you're not going to lose it. But while you're in state, we're going to simply expand what you're getting under Medicare. We'd be covering you with no co-pays, no deductibles. We'd be covering dental. We'd be covering eye care. We'd be covering things that Medicare doesn't cause, like lymphedema sleeves. We'd be covering long-term care. So we'd be covering more than Medicare, and the money we paid into Medicare, we'd be asking the federal government to give us back that. If they won't do it, Medicare would cover you first, and then we'd step in to cover the gaps afterwards.
Okay, great. Here's another. How does this compare to Minnesota Care?
Minnesota Care was, I voted for Minnesota Care 20 some years ago when it passed, and I think it's been a big improvement. It's one of the best, or it's Minnesota's public option in a sense. For people who make too much for medical assistance or Medicaid, it covers them. And it's a very decent plan in that sense. It doesn't cover everything. Some of the gaps in it, such as a cap on hospitalization coverage, has been taken care of in the last few years. One of the problems with Minnesota Care is you're covered for it, but you know, if you've got kids who are over 26 and so on, they're not covered. So it doesn't cover everyone is one of the biggest problems with it. And you do have co-pays and deductibles, and the premiums aren't, they're a little bit based on ability to pay, but that's only covering that part. It doesn't cover all the things that aren't covered. It doesn't cover all the co-pays, deductibles, and so on. So I don't want to bash the program, but the main thing, if we made Minnesota Care available to everyone, it'd be a huge step forward.
Could you clarify the 150,000 job loss number? Is that in Minnesota?
That's the number of jobs, that's the job turnover every month. 150,000 people leave their jobs either because they're retiring, they're being fired, they're finding a new job, or they're just whatever. All causes together is about 3.5 times as many jobs as would be lost one time in the transition. And because we have a couple-year period to do this, you plan ahead. And bottom line is, I'd argue that it might be, if you took everybody who worked in the insurance field and just had them sit at their desks and do nothing, it might be cheaper than what we're doing now. That's a terrible waste of human talent and human resources, and it's not a cheap way to do it. The simplest way to do it is make sure we retrain people and get them help getting other jobs. And again, there are a lot of people who work in the insurance and billing departments of hospitals. There are a lot of people who work for insurance companies who are medically trained. We could use them to fill some of the gaps and shortage of coverage. So we'd be saving a lot of those folks don't even need retraining. They'd just be switching what they do. And like in Minnesota, one of the insurance company health plans, Health Partners, they're not just an insurance plan, they're also a healthcare provider. They have hospitals and clinics and doctors. Some of them, you could keep working for the same company even, just switch over to the medical care providing.
Great. Can you talk a little bit more about the budgeting, and can the MHP exceed its budget by a pandemic or other catastrophe?
See, that's one of the issues why, first of all, in terms of pushing for this, I very clearly talk about Medicare for all. I wouldn't use that terminology as much, but that's the popular term now. Medicare itself is getting torn apart and privatized and covers fewer and fewer things, it seems. So it's fewer percentages of what we need to be paying for. But I would rather healthcare be covered at the national level. It avoids the problem that we have, because we have to have build up reserves to cover for a pandemic and so on. But we would be allowing the health plan, in order to be stable, has to have reserves built up. We would be trying to capture some of the money that's in reserves in the system now. Again, the health plans, the major health plans, most of their reserves have actually come from public programs. Until last year, and all the big ones are all still not for profit, so they don't have shareholders to compensate. I think we should be going aggressively working to try and capture some of that to build up our reserves quickly at the beginning.
All right. For many years, the Minnesota Department of Health has argued that more disease prevention will solve the healthcare spending problem. Do you agree?
I don't argue we should do health prevention because it saves money. Some cases I would argue it does save money. Other things, and a lot of things, what's prevention? Is mammograms, are they prevention? Or no, that's actually diagnosis, or diagnosis of a potential problem. And people often say, well, that if you count that as prevention, well, the number of people it catches earlier and so on, they save a few lives and so on, but does it save money? Well, that's not really a prevention measure, but I don't want to argue that it's going to save money or not save money. What I'd argue is we want our goal, Minnesota Health Plan goal, is to have the best healthcare system in the world. That means keeping people healthy. We have huge things. If we can turn around, if we could have wise investments in obesity prevention, that could save huge money on the system over the years. Smoking prevention has done huge things to save money, but we don't do this to save money. We do it to save lives, and I think that's the way you have to look at it. I don't see that as a factor that we can count on to save lives. I think we should do it because we want a good healthcare system.
So we've had a couple of questions about the effect of something like the Minnesota Health Plan on the Mayo Clinic and other health systems. Mayo tends to take patients who are private pay because they like the bigger payments. Someone's suggesting, wouldn't Mayo just close other hospitals and move out of state if they weren't making as much?
First of all, Mayo is doing very well, and it is, remember, it's, quote, not for profit, though its decision making is based on a corporate model that very much is making profit decisions. Mayo Clinic would probably be affected less than some, like universal global budgeting for a hospital, where we pay an annual budget, we negotiate a budget with the hospital. Mayo Clinic is a system that has a huge chunk of their patients come from out of state. So they'd still have a huge billing department, a lot smaller than they do now maybe, but they'd still have a huge billing department. We'd be negotiating with the Fairmont Hospital. We'd be negotiating with the Albert Lee Hospital. We'd be negotiating with these rural hospitals on their budgets. If some of their budget's gonna be paid to Mayo for administration, that's fine. Mayo can still administer them if it's in their interest to, but I have a feeling hospitals Mayo would decide, well, these rural hospitals, maybe that's not in our mission anymore. We'll let them go locally, but we'd be negotiating with the individual hospitals. With some providers, you're mentioning the big hospital system. Would Mayo Clinic move out of state? I don't picture them having any reason to. I picture a lot of the best things for advancing care and highly skilled care would be something you'd want to be in Minnesota for. What about doctors moving out of state? I think you could find a whole ton of med students who would move to Minnesota to practice medicine because they don't have to deal with the prior authorizations and deal with the billing and have to counsel their patients when they find out they can't afford the drugs they're prescribing. It makes them able to practice medicine, which is the reason most people go to med school. Most people don't go to med school to figure out how they can get prior authorizations for things. So I think it would increase the number of people who want to practice medical practices in Minnesota, make their job so much more simple. But yeah, some hospitals, Mayo, they would continue getting their patients from out of state, but they're not supposed to. Hospitals are not supposed to be turning down people because they can't afford to pay things. They're not supposed to be doing that, but and I know one way or another it's sort of been happening.
So Minnesota hospitals often have a bed moratorium, and that can contribute to the push to close hospitals. So how would the Minnesota Health Plan address this? Through the budgeting?
Sure. I don't think we need to have a hospital moratorium anymore because the budgets hospitals have for their capital changes for getting more beds and so on would be determined by the planning of the healthcare system, not based on the needs. When Health East or M Health Fairview now, I guess, when they took over Health East and decided they were going to expand coverage and options for people in the East Metro area. That was their press release. What they do? Well, they're going to cut down St. Joe's Hospital. The place where more people get addiction treatment and mental health treatment, low-income people particularly, than anywhere. They were shutting it down, not because the need isn't there, but because it doesn't fit their budget model. And so to us, where you're paying St. Joe's Hospital be providing the care they do, I think it works well.
So we have a question about being a Minnesota resident. What would be the parameters for deciding that you are a Minnesota resident?
Yeah, okay, well, it's a simple one which people will attack, but it's also one of the benefits of it, and that is that you live here, you're a Minnesotan, we're going to cover you. In order to stop people from moving here from that, because if I live in Iowa and I have no health care, no health coverage whatsoever, and I get cancer, heck, I want to be treated, I'm going to want to move. Well, we want to, and this is one of the issues with getting a local state plan, that we'd be asking the federal government for us to be able to bill other states for patients that are coming up here. Patient has no incentive to, they come up here if they say, I can't afford healthcare, I'm moving here because I want healthcare. We'd have pretty clear evidence we do. They're not going to be denied coverage for it because we want to cover everyone. But again, we cannot pass Minnesota health plan and just happen on our own. We need federal approval to do this. And I'm not trying to minimize how hard that may be to get. Trump administration is clearly not going to do that. But what we'd be telling the federal government is, hey, under the Affordable Care Act, you said you wanted to cover everyone. Well, we're going to cover everyone. We're going to take care of that problem for you. We're going to make sure 100% of Minnesotans are covered. But if other people are sending people here because they don't do what they're supposed to be doing, well, we need your help in letting us bill them. And hospitals right now, we compensate Hennepin County because HCMC has more patients, high needs patients coming from around the state. They're not the responsibility of Hennepin County taxpayers, so the state does step in and helps to try and balance that.
Let's talk a little bit about physician pay. Do you foresee physician pay being less?
They may be getting, physicians may have some of the charges they're paid, maybe, like, matter of fact, the way we compensate them may be significantly different. We may be paying much more, not for the doctor sees you for a half-hour appointment and they get paid more for ordering more things. That doesn't take any more of their time or expertise. Pay more for the time. If they're doing sutures or something else, it's a procedure, maybe you're paying for that, but you pay more for that. But how much they get paid overall? Well, their clinic might be paid less for their service, but if they have a huge reduction in billing clerks, if they have huge reduction in trying to collect payments that they're owed, if they have to just send the bill in electronically to a Minnesota health plan, it gets paid right away, it saves their administrative costs enormously. They said, since the Affordable Care Act, there was a study that came out several years ago that said that the average physician, the additional time, administrative burden per physician for administrative things related to quality measures on how we're paying for quality, because that's going to be a more efficient way to pay, averaged over 15 hours per physician. I think it was 2-point-some hours per physician per week, plus another 13-some hours of staff time per week for every physician, almost a half-time person, including some of the physician's time, just on filling out forms for these quality measures for payment systems in place. You take all that away, you can pay the physician significantly less, the physician's clinic significantly less. Physician might actually be better off. But what I'm saying is you're going to pay some people, I would argue general practitioners and people in underserved fields are going to be paid more. Some may be paid less. But the whole system would be paying out less because you're not paying for a huge administrative burden.
So we have a comment. I'm on original Medicare, no copays, a small deductible, no paperwork. Why is a Medicare for all type of system such a tough sell to some voters?
I didn't hear that.
Why is a Medicare for all like system so tough of a sell to voters?
I don't think it's as tough of a sell to voters as you think. The polls have fairly consistently shown somewhere around 55 to 60% of the public supports the concept behind it. The trouble is you're being told all the time, oh, it doesn't work. It's going to be government-run healthcare. It's going to be whatever. I think to that person on Medicare, there's less government intrusion, less insurance company intrusion, less everything else intrusion in your healthcare under this. So it shouldn't be a hard sell, and I don't think it is a hard sell. The only thing is we're up against a lot of big money who are defending the current system. Our pharmaceutical pricing system, we haven't even talked about that. I mean, it's bizarre. Nobody can argue that that's logical. People are angry about it. And so I think it's one we have to educate and do it. But I don't think we'll spend the next 10 years educating people. I think what we try and do is we try and educate the policymakers. We try and make the case for it. We don't have a choice. You look at that film that we saw at the beginning. You look at the film where we've gone from, can't remember how many, 30-some billion to going to be 98 billion in 7 years. We can't afford what we're doing. And to me, we don't have a choice.
Absolutely. I totally agree with you. Thank you so much, Senator Marty. We had a number of questions we couldn't get to, but we're going to have to move on. We'll see if we can get to those questions through an email. So now we're going to bring up Ann Jones, and she is going to talk about some resources, upcoming events, and a call to action.
Thank you for your patience on the steps that it takes to get change speakers here. I am a retired registered nurse working hard to fix how we pay for healthcare in Minnesota and the US. Senator Marty is a leader, a visionary, and a champion for fixing this problem. We do have some support in the legislature. We do need a co-sponsor, a new co-sponsor on the House side this upcoming session. I'm going to talk a little bit about educational events we've got coming up in support of educating the public. Our three main areas of work as Healthcare for All Minnesota, which is a volunteer nonprofit organization working to promote comprehensive, affordable, high-quality healthcare for every Minnesotan, eventually throughout the country through advocacy, education, and community organizing. Today, you've listened to one of our educational and outreach programs, and we're organizing to build a base of support so that we can get the public to get behind this with sufficient political will that we can make some progress. And then our third process is to work with legislators to pass and implement healthcare financing reform. We've got some events coming up, including a debate between Senator Marty on the DFL side and Senator Jim Abler on the GOP side, sponsored by St. Joan of Arc, which is one of our Healthcare for All Minnesota groups. And that is October 1st, 7 to 8:30 p.m. You're going to get an invitation for that. The registration will be a little bit different. It's a Eventbrite event, but you'll get an invitation from Healthcare for All Minnesota, and hopefully you'll be willing to go through the registration process for that and attend this. This should be interesting. On October 5th, we have a panel discussion sponsored by a Physicians for National Health Program Minnesota group in Rochester, and it will be on rural health issues, specifically the problem of loss of healthcare facilities in rural Minnesota. On Wednesday, we're going to do a noon webinar on being a healthcare voter and some of the things you need to know and pay attention to about voting in this COVID-19 era. And please, as activists, please continue to call, write, and respond to action alerts when you get them from us. See the calendar on our website for other meetings and events, and that's healthcareforallminnesota.org. And then again, we need grassroots support. Senator Marty needs some help. We need a lot of people power to get this change done. Even with people who, you know, lean towards supporting this as a solution, there's still a lot of political will to be created to make a change that is this significant. You're going to get the slides from this presentation in your post-webinar email, so I won't go through all of these, but I will really highlight there are some really good videos for good talking points and to reinforce some of the information you heard today on the fixithealthcare.com website. And I really encourage reading Senator Marty's book, The Case Healing Healthcare, Case for a Common Sense Universal Healthcare System. It's on our website. It is a really good presentation of the policy, the proposal, the transition plan for a Minnesota health plan. Other organizations working on this nationally, there's a lot of work being done. Tap in wherever you think you can be helpful, and lots of information out there, including support from labor. And I know that during the run-up to the nomination process here for this presidential election, you did hear some talk that labor is not with us on this. In many cases, they are. Groups are starting to understand that the amount of money we spend on administrative costs and the effort that has to be put in for employers and employees to make this current system work, and the taxpayer subsidies to make it work, are outrageous, and that we need to change. Lots of things that individuals can do. I will just go right to, for the next 45 days, 44 days, we really need to build the political will for change, and that involves election 2020. The more you can do to support candidates who are with us on this issue, the better off we'll be when the next session starts. Elections really matter. We do need a legislature that is friendly to this issue, and the majority sets the agenda. So we need a majority in both the House and the Senate who are with us on healthcare payment reform, and that involves flipping some seats in the state Senate. Whatever you can do between now and election day to make sure that you are a healthcare voter and you're informed on the positions of candidates, and then see if you can support some candidates in any possible way. And then we're going to have to push hard for change. Thank you for attending this event today. Dana, do you want to talk a little bit about what they're going to hear from us post?
Yep, so the webinar has been recorded. It will go up on our Healthcare for All Minnesota YouTube channel. We'll send out a link to those that attended and those that registered. You're free to share that link with others. There'll be some other resource links in your post-webinar email that's going to be sent 2 days from now. And look for our upcoming webinars that Ann talked about. Thanks so much for joining us today, where our webinar has concluded.